Wednesday morning running cardiology rounds. Today, Dr. Renee Boudreau, he was one of our cardiology residents, now he's an interventional cardiology fellow, is going to be talking about the DanGer AMI trial, which was presented at the ACC earlier this year and presented in New England, and how it's going to potentially impact care at our center. So welcome, Renee. We look forward to your presentation.
Perfect. Thanks for the introduction, Dr. Satnik. I'm Renee, one of the interventional cardiology fellows here in Ottawa, and I'm excited to have the chance to present my talk, which is titled Acute Myocardial Infarction, Cardiogenic Shock, and Old Danger with a New Treatment. Special thanks to my supervisor and mentor, Dr. Shaw, for all the help in preparing this talk and some of the data we'll be discussing today. So this is the outline of my presentation. I'll review the background on MI shock, go over some historical trials, then I'll discuss the recently published DanGer trial and finish off with some Ottawa-specific data and introduce our proposed acute myocardial infarction protocol. We'll start with a case presentation. This is a case of a patient who presented here in Ottawa. She's a 47-year-old female known for remote smoking history. She had intermittent chest pain for 4 days, saw her family physician who had organized for a treadmill stress test. While she was waiting for the stress test, on the night of her admission, she had severe chest pain starting around 11 p.m. She was found by family conscious but very dyspneic. EMS ECG showed a STEMI, and she was brought to our STEMI bay as a code shock. Or as a code STEMI. Her ECG showed sinus tachycardia and a high lateral STEMI. In the STEMI bay, she was agitated and in respiratory distress and therefore intubated. She was shocked for VF. Norepi and vasopressin were started. She was taken to the cath lab urgently as a code shock was called. They rapidly obtained bilateral femoral artery access and right venous access. A diagnostic angio showed a flush occluded left main. They only fluoroed that picture, so I don't have a cine of the left main. They got it out of there relatively quickly once they took their diagnostic shots. She was hypotensive and tachycardic on pressors. The left main was wired and ballooned. After ballooning, she became unstable and given fennel, and a balloon pump was placed. This is the flow down the left main LAD and circ after ballooning. As you can see, the flow is quite sluggish. They proceeded to stent the left main. Almost immediately, the patient arrested and CPR was started. After a period of resuscitation, a decision was made for ECMO, which was rapidly placed. She was escalated to LVAD on day 3. Neuroprognostication suggested poor prognosis on day 10, and care was finally withdrawn on day 18. I highlight this case to show you how sick these patients can be. And I also show this case because a patient had a bad outcome despite excellent care based on the best evidence at the time. Over the next hour, we're going to discuss the newest evidence in the field and will hopefully be able to, in the future, improve outcomes for patients such as this. Now on to the background. Cardiogenic shock is a severe complication of STEMI and is associated with mortality of over 50%. As shown on the figure on the right, on the figure on the right, cardiogenic shock represents about 67% of all shock, and MI shock 30% of CS shock. The only intervention shown to reduce mortality is revascularization of the culprit vessel. Because cardiogenic shock develops when the cardiac output is inadequate, restoring perfusion with active mechanical circulatory support is theoretically beneficial. Unfortunately, prior intra-aortic balloon pump and ECMO trials have been negative. So now on to the current trials that have kind of shaped our practices. So the story starts with the publication of the shock trial in 1999 by Dr. Hockman. It randomized patients presenting with MI shock to medical therapy or immediate revascularization. The primary outcome was death at 30 days, which was negative, but at 180 days, they saw an improvement in mortality of 13%. This is kind of the first therapy to show benefit in MI shock. Our next positive study came in 2017. This study by Thiel randomized patients with multivessel disease and shock to multivessel PCI versus culprit only. They found that doing culprit only PCI was associated with a 10% reduction in mortality at 30 days. There are several reasons this trial may have been positive. The first is the patient has already suffered a significant injury to the LV, leading to the cardiogenic shock. Therefore, a procedural event when PCIing the non-culprit vessel would likely not be tolerated well. Secondly, fixing a non-culprit vessel requires extra contrast, which is a negative inotrope, and can also injure the kidneys. So for those reasons, those patients may not have tolerated that very well. And this has led most interventionalists to keep things simple when PCIing patients with MI shock. Now onto our device trials. The first published in 2012 in New England by, again, Dr. Thiel and his team, randomized patients to intra-aortic balloon pump versus standard therapy. There was no difference in the primary outcome of all-cause mortality at 30 days. This has resulted in a designation for a class 3 intervention in the European guidelines for routine intra-aortic balloon pump use in this population. Thiel and his group then turned to ECMO with a publication of ECLS shock published in New England Journal of Medicine in 2023. It randomized patients with AMI shock to either standard therapy or ECMO. They found no difference in their primary endpoint of all-cause mortality at 30 days. There was an increase in bleeding and there was an increase in limb ischemia in the ECMO group. So now on to the DanGer trial. After a series of negative MCS trials, the question everyone must be thinking is why another MI shock MCS trial? And the answer to that lies in the hemodynamics and patient population that they selected. In the microaxial flow pump, which for ease I'll call Impella for the rest of the talk, has a much greater cardiac output than intra-aortic balloon pump, whereas compared to ECMO, it reduces afterload, where ECMO increases afterload. Finally, the two previous trials had a high proportion of patients who received CPR for an out-of-hospital cardiac arrest prior to their presentation, and therefore had a high proportion of patients who suffered neurological deaths. So now onto the actual trial. As most of you know, the DanGer trial published by Moeller and his team was presented at ACC April 7, almost 2 months ago, and simultaneously published in New England Journal of Medicine. They hypothesized that using Impella CP on top of standard care in patients with MI shock would result in a lower mortality. These are their endpoints and sample size calculations. We'll go over them individually when reviewing the outcomes. They include patients with STEMI shock. They defined cardiogenic shock as peripheral signs of hypoperfusion with either a lactate over 2.5 or a mixed venous sat under 55% and a systolic blood pressure under 100 or need for vasopressors. They only included patients with LV function under 45%. They allowed for patients with STEMI and STEMI equivalent, which they defined as ST depression or left bundle branch block with urgent angiogram showing proximal vessel occlusion. And finally, they allowed patients into the trial who developed shock up to 12 hours after revascularization. Their exclusions are shown here. A few of the important ones are comatose survivors of out-of-hospital cardiac arrest, which they defined as GCS under 8 at presentation, severe RV dysfunction, mechanical complication, and life expectancy of less than 1 year. This figure shows patient recruitment based on year. When the trial began in 2013, it initially only had 3 Danish sites. You can see recruiting really took off in 2019 when several German sites were added, and again in 2021 when a UK site was added. From a trial perspective, it's kind of incredible that a country like Denmark, with a population under 6 million, was able to recruit over 2/3 of the patients in this trial and answer a very important question in the field of cardiology. It really shows that you don't need to be the largest city or country to do impactful work, but you really just need the right people and the right infrastructure. They screened 1,211 patients and randomized 360, 180 to standard care and 180 to Impella. Of the patients screened, the majority were excluded as comatose survivors of out-of-hospital cardiac arrest. I want to start by outlining the study's outcome as a hook to keep everyone interested when we take a deeper dive into the protocol and methods. The findings of the primary outcome, which was all-cause death at 180 days, showed an absolute reduction of 13%, which translated to a number needed to treat to prevent 1 death of 8. Reviewing the cause of death from the appendix, we can see in the first 30 days, there's a large reduction in cardiac-related death. Then between days 30 and 180, there is a reduction in death related to multi-organ dysfunction. This is only hypothesis generating, but as a proof of concept, it seems to show that reducing afterload early helps decrease cardiac mortality, and by increasing circulatory support, prevents later irreversible multi-organ dysfunction. Regarding subgroup analysis, I want to highlight 5 subgroups. The first, although age certainly should play a role in selecting patients who should go on temporary mechanical circulatory support, in this trial, Whether you were older or younger than 67 didn't matter, and you benefited from the intervention regardless. The second is patients with a lower blood pressure seem to get a greater benefit than those with higher blood pressures. This is interesting because this trial recruited patients with a blood pressure up to 100, while the other shock trials recruited patients with a blood pressure under 90. The third is that it did not matter if you had an anterior or non-anterior MI. The fourth is that patients with multi-vessel disease seem to benefit more than patients with single vessel disease. Left main in this analysis was treated as two vessel disease. And then finally, it didn't matter if you had SCAI C, D, or E shock, you seem to benefit. All too often, we seem to wait until these patients are on multi-drug therapy as far as pressors and closer to the SCAI D or E before we consider MCS. This suggests that we shouldn't be waiting. The secondary endpoint of escalation to short or long-term MCS, transplant, or death from any cause at 180 days was positive for a hazard ratio of 0.72. There are other secondary endpoint, which was days live out of the hospital, was numerically lower for the Impella arm, but not statistically significant at 82 versus 73. Although this treatment decreases mortality, it isn't without cost. The first I want to discuss is a longer hospital and ICU stay. In total, there was an additional 5 days in hospital for patients treated with Impella, which translated to 3 additional ICU days and 2 additional ward days per patient treated with this strategy. And now the adverse events. In the treatment arm, not unexpectedly, there was more bleeding, more limb ischemia, and a greater risk for sepsis. What was surprising initially was also the higher risk for renal replacement therapy in the Impella group. At this point, it's unclear if this is survivorship bias or if there's something inherent to the device that seems to impair patients' renal function. This increase in adverse events speaks to the need for protocolized mechanisms for both patient selection and downstream care, as we want to target patients who will benefit the most from this intervention and we want to reduce adverse events. So now that we've discussed the main findings of the trial, I want to take us a little bit deeper into the protocol so that we can understand how best to apply this in Ottawa. A key protocol component I want to highlight is that they performed an echo on the table while the patient was being prepped. This was to ensure that the LV function was under 45% and that there was no significant RV dysfunction. They then obtained femoral access and sent for a blood gas immediately, only including patients with a lactate over 2.5. Finally, after doing that, they performed a diagnostic angiogram to identify the culprit vessel. After those 3 steps, if the patient met all criteria, they are randomized before PCI with insertion of Impella at that time. If patients again develop shock in the 12 hours following PCI or develop shock after PCI in the lab, they could be randomized at that time with insertion of device then. So the included patients, 55% were randomized prior to PCI, 27% in the lab after PCI, and 18% within 12 hours of leaving the lab. Of the 55% randomized prior to PCI, 85% received the device before they actually ballooned the vessel. So that translates to 47% of patients received the device before opening the culprit vessel. Following PCI, all the patients were monitored with an ART line and a Swan-Ganz catheter. The figure on the right highlights their CCU treatment protocol. Unless complications requiring Impella termination, all patients continued support with Impella for 48 hours. At 48 hours, if they were on 2 pressors or less with stable hemodynamics and they had specific kind of targets for their hemodynamics on the right heart cath, then weaning was attempted. If weaning failed, then they recommended no further weaning for an additional 48 hours. And of course, if at any time patients were unstable, they considered for escalation of support. This is their table 1. The median age was 67, median lactate was 4.5, 72% of patients had either left main or LAD disease. Symptom onset to randomization was 4 hours, median EF was 25%, and 55% of patients were SCAI C and 45% were SCAI D or E. The median time from randomization to Impella insertion was 14 minutes, highlighting that these sites had a lot of MCS or Impella experience. Over 40% of patients in both groups underwent non-culprit PCI. And if you remember, this study started several years before culprit shock was published, so that might be why there was significant non-culprit PCI. They escalated to VA ECMO in 12% of patients in the Impella group and 19% of patients in the standard therapy arm. Now that we've gone through the trial in detail, the burning question really is, why was DanGer positive when the other large randomized MCS trial is negative? And I think a big part of that we're seeing that Impella 1 versus the other studies is its hemodynamic profile. So this figure shows kind of the three main hemodynamic goals of any MCS therapy. The first on the left is circulatory support. This is where you can see aortic balloon pump seems to lose. Aortic balloon pump provides very little cardiac output, whereas Impella does provide significant output. The second is ventricular support. Here, VA ECMO actually increases afterload, whereas Impella reduces afterload, given an LV that's had a significant injury, some time to recover, and also protects them from reperfusion injury. And then finally, coronary perfusion. Again, here Impella wins as calculated by MAP minus LVDP. Besides the mode of therapy, it's also interesting to look at how DanGer was conducted compared to the other trials. DanGer selected for LV pump failure by having patients have a mandatory TTE prior to randomization, where the other trials didn't, and that resulted in lower LV functions and likely less RV dysfunction, although we don't have those numbers for the other two trials. Next, the other two trials had significant proportion of patients with out-of-hospital cardiac arrest at 45 and 77%. And then finally, despite DanGer excluding patients with out-of-hospital cardiac arrest and comatose patients, they still had a lactate that was as elevated as the other trials, and their treatment group, their standard therapy group actually had mortality that was higher than the other trials, highlighting that these were very sick patients, even though they excluded comatose survivors. And then finally, by excluding comatose survivors, they had a very low rate of neurological deaths at 1.67% versus 12.6% in ECLS shock. And this is important because the neurological injury to these patients would happen during their arrest prior to arrival to the hospital. And this is something that is irreversible, or at least not reversible by a device therapy. So if there's one takeaway from the DanGer trial, it's patient selection. It really is the right strategy for the right patient. And the right strategy is MI shock, which they described as systolic blood pressure under 100, lactate over 2.5, and EF under 45%. Predominantly anterior MIs, no comatose survivors of out-of-hospital cardiac arrest, and no RV failure. So in summary of the DanGer trial, but not my whole talk because we've got one more section to go. DanGer, a strategy of Impella in patients with MI shock compared to standard therapy, reduced death by 13% with the number needed to prevent one death of 8. It's the first positive MCS trial. The treatment strategy was associated with lengthened ICU and hospital admissions and a greater number of adverse events. Given the clear benefits and cost of the strategy, protocols for patient selection optimal care must be created. And that takes us into our last section, which I've titled Adopting DanGer, a proposed Ottawa model. So after the publication of DanGer, we want to know how many patients in Ottawa would potentially benefit from a strategy like this. We've been working on this for the last couple of months and submitted this as an abstract to CCC and are currently writing up the manuscript. We took 13 years of data from Ottawa's primary PCI STEMI database, consisting of almost 6,000 patients, and applied the DanGer inclusion-exclusion to estimate how many patients would be candidates for this treatment strategy. We initially screened for patients who had hypotension, required pressors, had an intra-aortic balloon pump inserted during their initial cath, or KILP4 presentation, or had an MD diagnosis of shock. This represented around 10.5% of our STEMIs, or 625 patients in total. The charts for those patients were reviewed for what we would have traditionally called cardiogenic shock, which was hypotension and at least one marker of hypoperfusion, which was a lactate over 2.2, low urine output, cold or cool extremities, altered mental status, or an admission diagnosis of shock by the treating physician. And that led us to 334 patients that we would say had classic shock. On the right, you can see we then applied the DanGer exclusion criteria. On the right, you can see that we actually excluded 65% of patients that we would say had traditional MI shock. And that highlights how, again, how selective the DanGer trial really was in their patient selection. Of these patients classified as classic shock without exclusions, we classified them as needing DanGer if they had an admission lactate over 2.5 or an EF under 45%. The likely met criteria that we have over here, these are patients that either did not have a lactate or an LV assessment during their admission. This is predominantly patients that either died in the cath lab prior to LV assessments or lactates could be drawn, or died early in the CCU. And again, this highlights that this is a very sick patient population that likely requires an early intervention. As we already had classified these patients as traditional cardiogenic shock, despite not having these measurements, we classified them as likely meeting danger. So the final result is 114 patients, or 1.93% of our STEMIs between 2004 and 2017 would have met or likely met danger and potentially benefited from this treatment strategy that included Impella. In other words, a retrospective analysis of the Ottawa Heart Institute STEMI primary PCI cohort indicates that only a small proportion, under 2% of patients presenting with STEMI would qualify for a danger-like strategy, and this represents about 8.8 patients per year. This table compares patient characteristics in our retrospective analysis who met danger, those that likely met danger to the actual, and the combined cohort to those in the actual danger trial. The median age for all of these was 68. Now looking at our combined cohort and the patients in the danger trial, we can see that our admission lactate was quite similar to the danger trial. In Ottawa, over 50% of these patients were treated with an intra-aortic balloon pump. Our mortality was 49% compared to 45 in the danger treatment group and 58 in the standard therapy group. One possible explanation for our lower mortality is that because this was a retrospective analysis and we didn't have GCS, all patients who had a possible cardiac arrest but were intubated either en route or at peripheral centers were excluded from our trial. Some of these patients, if their GCS were over 8, would have actually been in danger. So it's possible that we excluded some of our sickest patients from this retrospective analysis, or it's possible that our institution outperforms the centers in the danger trial. When considering adopting a treatment strategy similar to danger, we really need to consider the costs associated with this treatment strategy. Using data from the danger and assuming that we place about 10 devices per year, this would amount to 2.5 additional CICU bed days per month, 1.6 additional ward bed days per month, 1 additional bleeding event per year, and 1.5 additional renal replacement therapy per year. These costs highlight again that we need to apply this strategy to a highly selective population and create optimized systems of care to minimize these adverse events. I think it's important to remember that these are not new patients added to the system, but these are patients that were already taken care of here at the Ottawa Heart Institute. They're typically looked after by the CICU and interventional cardiology team, and many of them undergo our current code shock protocol, which I've highlighted on the right here and was published in CJC in 2020. In the first 3 years of our code shock protocol, 64 patients underwent the kind of code shock algorithm. 7 of these patients were MI shock. 45% of them received temporary mechanical circulatory support. So these patients are there, and some of them are already receiving MCS. So what we're trying to do here is that we're trying to pick a specific phenotype that now has randomized data and give them the care that we think they need in a faster way to complement kind of our current shock team. So when creating our algorithm, in addition to reviewing the literature from the DanGer study, we also want to know what other centers are doing. This slide shows an example of how several centers in the United States are using the Impella treatment strategy in MI shock. This is from a 2023 publication in Journal of American Heart Association. This is the USA's National Cardiogenic Shock Initiative based on the Detroit Shock Protocol. It's important to note that this was created over 10 years ago and has been modified several times since, but has not been updated since the publication of DanGer. Something else that's important to note is that in the United States, costs per device are paid by insurers and patients, whereas in Canada, these costs are shouldered by hospitals and the government. So going through their shock algorithm, they select for patients with STEMI or NSTEMI and cardiogenic shock. They have to have 2 of 3 hypotension, signs of hypoperfusion, or clinical sign or right heart cath measurements suggesting cardiogenic shock. And this is a lot more aggressive than DanGer because theoretically a patient could meet criteria with having pressures on board and having cool extremities without any actual hard evidence of hypoperfusion, such as an elevated lactate. And then second, they don't mandate pre-device insertion echoes, so they're not specifically selecting for LV pump failure, and they may actually have some RV dysfunction in their groups. And then finally, they suggest inserting an Impella prior to coronary angiogram or PCI. So again, they don't even know what culprit vessel they're dealing with. They just have shocky patients with MI and they're putting in devices. So based on everything I presented today and incorporating the values of our Canadian healthcare system and with input from many of our local experts, we've created what we believe is the first Canadian AMI cardiogenic shock protocol. We know that since DanGer's publication 2 months ago, many Canadian centers will be looking to make protocols such as this, and we hope to be leaders in the field. Our goals for this protocol to be adopted in several centers for clinical use, collecting data, and launching future trials in the MI shock space. This is preliminary protocol, and we hope to receive feedback today and in the coming weeks as we finalize this protocol. We want this treatment strategy to work here in Ottawa, and for that reason, you'll find that our proposed protocol is much more selective than the US Shock Initiative and even more conservative than the DanGer trial. So I'll take you through our protocol now. So step one is identifying patients with possible MI shock. To be considered for the protocol, patients must meet all three of the following. They must present with STEMI or STEMI equivalent. They must be hypotensive or on pressors and suspected to be in SCI-C or worse cardiogenic shock. They'll initially be assessed and managed by the CCU team, as currently happens with our code STEMIs. If they feel the patient is in shock, they'll review for initial exclusions, which you can see in the yellow box. These are similar to the DanGer DanGer exclusions, such as out of hospital cardiac arrest with comatose survivor, mechanical complication, other causes of shock, and so on. We really want to focus on patients with LV pump failure, and for that reason, patients with inferior STEMIs will be excluded if they're suspected of having RV dysfunction or have inadequate POCUS pictures to assess the RV. Based on the results of the DanGer trial subgroup analysis on age, which suggested that older patients benefit from this strategy. We didn't put any exclusions for age, but this is still in draft, and this is something that we consider adding in. Step two is the activation of the MI code shock. So the CICU team will discuss the case with the staff interventionalist. Calling an MI code shock will notify heart failure, perfusion, cath lab nurses, and CCU charge nurse. This will ensure that the proper equipment is brought into the cath lab, that the CCU team is able to make a bed that would be able to care for an Impella patient. With the recent training in the STEMI DTU trial, which is a trial that we've started here, that we are part of here in Ottawa that started this week, the cath lab and the CCU team has had training on how to place and start an Impella without perfusion, but we still feel that getting perfusion involved early will be important as far as optimizing care for these patients. And then finally, heart failure will be notified here, but don't need to be formally involved unless an Impella is actually placed. So patients then going to be transported to the cath lab. The patient's hemodynamics and suitability for an Impella will be confirmed. This will be done by obtaining femoral access, doing a peripheral angiogram to assess vasculature for suitability of a device insertion, sending a blood gas, performing a peripheral angiogram, performing a coronary diagnostic angiogram to confirm culprit vessels and measuring an LVDP. If the patient has no exclusions, has a lactate over 2.5 and an LVDP over 20, and doesn't have any exclusion criteria, then an Impella will be inserted at that point in time. And you'll see that we've put this green box here. This is for patients who were not shocky prior to going to the cath lab, or were kind of pre-shock, and then after PCI or during the intervention develop shock. Similar to DanGer shock, we think that these patients should potentially be included in this algorithm. So if they develop shock after the intervention, then an AMI code shock would be called then, and these people would be notified, and then they would again be kind of dumped down here, and you would then switch to a femoral access, assess suitability, and if suitable, would then have an Impella placed at that time. We think that since we have a robust code shock protocol in Ottawa, if they leave the cath lab and then become shocky in the CCU, then we'd recommend these patients go through our current standard code shock protocol. And then finally, step 4, or last step, is ongoing shock care. These patients will be managed in the CICU. The shock team, which will include interventional cardiology, the CICU team, heart failure, and cardiac surgery, will round on these patients daily to consider escalation and de-escalation, in addition to ensuring shock and MCS best practices. We really want to emphasize that this is a treatment strategy that includes an Impella, not just an Impella as a treatment. Because of the high number of adverse events, we really need to remain vigilant and develop best practices of care. So we hope to get this finalized in the coming weeks and published also in the coming weeks. It's still a draft, and we welcome some feedback today and kind of in the next few weeks. It's important to note that this does not replace our current cardiogenic shock protocol. This is to complement and strengthen the present shock program, recognizing that cardiogenic shock has many phenotypes and MI shock requires prompt identification and treatment. And in the DanGer the data in the DanGer shock is clear that Impella in this population decreases mortality, but there remains many unanswered questions. And I think there'll be a lot of exciting developments in this field. When you really think about it, Copenhagen's population is only 600,000 and Denmark under 6 million. So why can't Ottawa and Canada answer some of these questions? And this is where we hope to go next. So my favorite of these kind of unanswered questions is timing of Impella insertion. In the DanGer trial, about half of the patients received the Impella prior to PCI versus after PCI. And implantation of device prior to PCI is kind of current best practice, but that's based on animal models. So we don't really know, should we be PCIing the culprit vessel or restoring flow and then picking up the pieces if the patient crashes with the device, or should we be cooling off the patient first with an Impella and then opening the artery under mechanical circulatory support? So it's a really interesting question. And when we think about the patient case that I presented at the beginning, this patient crashed after the left main was ballooned. So if an Impella was put in up front, would this patient have made it through the procedure? Alternatively, that patient had already had significant VF, and delaying opening that left main could have led to incessant VF, and it may not have changed the outcome. Again, I think the future kind of studies will answer that question. And then I've highlighted some of the other kind of questions that still need to be answered in this field. One of them is best in revasc strategy. Is culprit shock still true once you put mechanical circulatory support in? Are you then supported to kind of PCI non-culprit vessels? How to best incorporate shock teams, when to escalate and what to escalate to, and then developing best practices for vascular access, closure, peripheral limb perfusion, healing protocols, renal protective strategies, and so on. So in summary, in the rapidly evolving field of MI shock, a treatment strategy incorporating Impella was shown to reduce mortality. This strategy was associated with increased adverse events, length of hospital admissions and stays, and cost. Using retrospective hard student data, we expect that approximately 2% of our STEMIs would benefit from an Impella treatment strategy. And finally, we've created the first Canadian AMI cardiogenic shock treatment algorithm and welcome feedback. Thanks for your attention, and I'll take some questions now.
Thank you very much, Renee. I think we're going to have a lot of discussion here. So let's start over here with Dr. Golian.
Thanks, Renee. That was a very good talk, and congratulations on the very nice protocol that you've set up. I think it'll actually change the field quite a bit. The question I had for you is that, so if you look at the inclusion criteria and exclusion criteria for culprit shock versus the DanGer shock trial, they're fairly similar. The mortality in the control group, as well as the mortality in the the experimental group, is also very similar. It's 45% versus 58%. Most of the mechanical circulatory support trials have shown kind of negative results, except this one. And the question I had, considering culprit shock came out more towards the end, and there was no real stratification of multi-vessel PCI versus target vessel PCI in the DanGer shock trial. Do you think it's potentially contributing to the difference that you see in there if they're unbalanced groups, considering there's only 240 patients? Or do you think the benefit would be actually even more prominent if they had done, culprit vessel only in the group that's actually getting the Impella?
Yes, so that's a super interesting question. Thanks, Dr. Golian. So if I'm understanding the question right, basically you're saying if a modern day strategy of culprit only PCI had been applied to this trial, how do we think the events or outcomes would have actually looked? So, I think really the kind of, that question will hopefully be answered within future trials, because you're right. In the culprit shock, it was shown that if you only PCI the culprit vessel, then you had a mortality benefit. And in this trial, they did 40% of non-culprit PCI. And you'd wonder, once you put in a device, does that actually favor the treatment group? And the fragility index in this trial was only 2. So if we shifted 2 mortalities to the other side, by using that practice, would this be a negative trial? I think that kind of remains to be answered. There's another trial coming out called Recover 4 that'll probably be published in 2027. That's Impella prior to PCI versus standard of care. So it's not Impella pre-PCI versus Impella after PCI, but Impella before, and that will have more of a kind of a modern day kind of PCI strategy. So I think that will be kind of the next trial that will confirm these findings that in these very sick patients, an Impella strategy does reduce mortality. I think until then, we probably do need to assume that this trial probably is actually reducing mortality, even with our current culprit shock practices. And the other thing is in culprit shock, a lot of the events were reduced kind of in renal outcomes. And realistically, both, in the Impella group here, we had more renal events. So reducing contrast and only doing kind of culprit PCI, for all we know, may actually favor the treatment group of an Impella, because then it may actually reduce the renal events. So it's hard to say. I think, it can kind of swing both ways, and we'll be kind of, excited to see what the next few trials kind of show for that.
Dr. Chan has a question.
Very nice talk, and you summarize the differences between the three big trials very nicely. I'm looking at it, since there's so much differences between the trial, wouldn't it be a better comparison if they have randomized, in the DanGer trial, randomized those patients based on their exclusion and inclusion criteria into either Impella versus intra-aortic balloon?
Yeah,
Because I think this is really, you cannot say that this is better than the intra-aortic balloon, because they were testing in different patient groups. So this is really, I think that is my concern. I think that the comparison really is, Impella versus nothing, right?
Yeah, and I think that's a fair question, but I think we have to kind of interpret this trial within the specific region that this was done. And if you remember, the European Heart Society recommends, or basically gives a recommendation of 3 or of harm for intra-aortic balloon pumps. So in Europe, they're not using intra-aortic balloon pumps for this specific patient population. I know that in North America, we're still using them, but there hasn't been any trials that have shown that intra-aortic balloon pump is superior to standard therapy. So I think, they compared it to what they're doing. And then they had some very clear kind of guidelines on when to escalate. And if you remember, in the control group, 19% of patients were actually escalated to ECMO. So instead of escalating to, or putting in an intra-aortic balloon pump in these patients, a fifth of them did get escalated to ECMO. And I think that's probably standard of care in Europe. Does intra-aortic balloon pump give some form of marginal benefit in this patient population? I think a lot of people still believe that. But again, the large negative trials suggest that that might not be the case. You're right, though, if we applied this specific patient population into an intra-aortic balloon pump trial, it's possible that we would now find benefit, because this is a different population than IAP2, mostly because they excluded comatose survivors of out-of-hospital cardiac arrest. So is it possible that this specific patient, this very highly selected patient population, benefits from a balloon pump, and that a balloon pump is similar in outcomes to Impella? I think that's very possible. And if, I think that would be an interesting kind of trial to have this very selected patient population trial done with a balloon pump. Unfortunately, I think, the cardiology world may have moved on from that because of, the previous negative trials, but that would be very interesting.
Dr. Chi has a question.
Just a comment to begin with. I thought that was excellent, Renee, especially like the fact that you reviewed the local data to have a really nice estimate of patient volumes that would fit. So I think you highlighted 2 really critical aspects of management of shock patients. First, the heterogeneity of this patient population. That's not me echoing, and that, the importance of separating MI shock from non-MI shock in terms of management. And then related to that is the importance of patient selection. And so with regards to patient selection in this protocol, which we've seen and reviewed, just a couple of questions. So one is to do with patient age, and that's controversial, but whether or not in this first iteration of such a protocol that should be considered an age cutoff. And also, secondly, did you see any information about timing from sort of onset of symptoms to unload or support in the actual study that might guide that as a particular exclusion criteria as well?
No, yeah, those are great questions. So as far as age, I think that, that's something that we've kind of gone back and forth many times because, I think the things that are pushing us to not including it is the subgroup analysis that showed that both patients over and under 67 benefited. But the flip side of it, and then the other fact is, these are not necessarily patients that we need an exit strategy for. The exit strategy is recovery of the LV, get them over their kind of, MI insult. So, if we do include patients who are older, this is kind of the treatment, and then, CICU best practices, and then try to wean the device. They're not patients that we're going to be escalating to kind of ECMO, LVAD, or transplant. So I think those are the arguments to not include it because these patients may still benefit it, and this is kind of their one chance to get over their large MI. But I agree that the reasons not to include is especially early on as our center kind of gets better at putting these devices in, we want to minimize adverse events and really help patients who will get the most benefit from kind of this expensive strategy. And we all know that older patients will have worse vasculature, higher risk of bleeding, and will not do as well with those adverse events. So taking all of that into consideration, I think it'd be very reasonable for us to have some form of relative exclusion, age over 75. And then as we kind of get better with this strategy, then, can we fade that in or out depending on kind of our first dozen or a couple dozen patients? I think that's something that, we've discussed and we almost added it in last minute. So I think that's something that, next time that we chat, we'll certainly kind of have a more in-depth discussion on if we should actually formalize that on this. I agree with that. And then the second question, as far as time of onset of symptoms to device. So the mean time of symptoms to randomization was 4 hours. They didn't have anything as far as subgroup analysis on who benefited. So it doesn't really help us. All we know is, these are relatively early presenters who got pretty early unloading of the LV. But it would be nice to, have some form of stratification by kind of, very early to kind of middle or late to see if there is a subgroup difference. But that's not data that's currently available.
I got a couple questions under comments. The first one, so you show increased CRRT rates or renal replacement therapy in your device group. You also comment that RV failure, overt RV failure is a contraindication to being randomized or having this therapy. So my question is, first, how are we defining RV failure? How are you assessing it? And is there more RV failure in your device group? And is that one of your potential reasons why you have more RV or more renal dysfunction? So that's my first question. Second question is, these devices are a little tricky to put in. And you're projecting 8 to 10 cases per year. And you've got, numerous cath lab operators. Some have more experience putting the devices in than others. And it's not practically reasonable to expect your most experienced operators to always be present. So from a logistics standpoint, what is the plan for, training operators, maintaining the level of expertise, that kind of situation?
Yeah. So maybe I'll answer the first question and I'll let Dr. So kind of chat a little bit about the second one as far as how the cath lab is organized and how they'll manage the personnel, because I don't want to step on any toes. So as far as the RV dysfunction question, so what they did is patients were taken urgently to the cath lab. On the table while they were being prepped, they had an echocardiographer actually do an echo while the patient was being prepped. They had very specific kind of criteria for RV dysfunction, which included, and I don't know the specific cutoff. So basically, they had a specific TAPC. They had kind of RV bigger than the LV. So they had very specific kind of exclusions on what meant RV dysfunction, and specifically it only excluded severe RV dysfunction that met those criteria that they outlined kind of in their protocol. But then after that, they didn't actually publish how many of them would have had mild or moderate RV dysfunction. So it's hard to say, how many of them actually had that, and if that does impact kind of renal dysfunction. Presumably, since this was randomized, you'd think that it'd be similar in both groups, but it would be interesting to know how much RV dysfunction, and then post-intervention, do the patients with Impella have even worse RV dysfunction because of the support? And does that actually play into the fact that more of them need replacement therapy because of, right-sided congestion? But it would be interesting to know that data, but I don't think it's available. Yeah, so everyone was brought to the CCU with an arterial line and a swan, and that's what we would recommend here as well.
Yeah, so first of all, I just wanted to thank Renee. He's really put in a lot of work into this, and certainly we really want this to work. So we want everyone's contribution in terms of ideas on how to improve this. And I just want to reiterate Sharon's point in terms of we want this to be successful at the start. So that's why we've got a much more conservative algorithm compared to what DanGer would be. To your point, Ellie, in terms of Impellas being difficult to put in, they're actually not, right? There's this myth that this is a very specialized device, but all of us have been brought up to cross the LV, do V-grams, get femoral access. And I would argue that modern day technology now, in terms of standard of care, we always do an ultrasound guided femoral or stab, so it's even safer. On the Canadian front right now, I've actually put a lot of effort in terms of getting good femoral large bore access. So I'm actually one of the co-directors of the National Fellows course. We actually have a specific station looking at femoral access. Shishan's one of the proctors, and we've got a station specifically at that. We've got stations in terms of all trainees on how to do proper closure devices. And so I think on a national front, this is something that we're developing. And I would argue in terms of the more senior of us that have been around for a long time that used to do femoral access without ultrasounds, if anything, we are quite comfortable with femoral access. So I really don't think that that's an issue. I don't think having only a few of us doing this is going to work because these are unpredictable, right? If we're looking at 8 cases a year, you can't have an interventionist that's doing STEMI call, but not be able to put in an Impella. And I think the realities of it, when you look at what has happened in the US landscape, in the US, because cost is not an issue, they put it in probably 5-10 Impellas per week in high volume centers because they do it under protected PCIs. So I think it's something we do need to work on as a group to make sure that we've got protocols in place, that our staff is trained in terms of how to get the devices started. But I do think it's going to work. And I think a lot of what you're seeing is what happens afterwards. So in terms of explanting the device, in terms of taking care of these patients afterwards, those are crucial aspects. And so that's why I think even on the Canadian landscape moving forward, every center wants to do this. But I think the key thing is not just putting in the device, but how to take care of them afterwards. And in smaller centers, if you do not have an ICU setting that can have renal replacement therapy, that can deal with sepsis, that basically have to carry these patients to that finish line, those are things we need to think about because some of these smaller centers might to think about how you're going to transfer a patient out. And then the other thing that Renee briefly touched upon is that there are lots of patients within DanGer that had an escalation of devices, right? That they actually went onto ECMO, went onto a 5.5 Impella. And I think those are things that we need to do and think about as a team. And that's probably a more important aspect rather than just putting the Impella at the start.
Any other questions or comments from the audience or anybody online? If you have a question, please put it in the chat box. Dr. Beanlands.
Renee, great presentation. Thank you very much. Exciting work. How will you assess the RV function? You're going to do that with POCUS? Or
Yes.
you-
So basically in this algorithm, so if you remember most patients in DanGer, almost 80% of them had anterior MIs. So we've put a number of kind of checkpoints into this protocol so that we're very choosy with our inferior STEMIs. So the way that we're going to do it is similar to how it's done currently. We'll ask the CCU team to initially do a bedside POCUS. If there's any concern for RV dysfunction, or if the POCUS images are inadequate to assess the RV, then we're going to exclude those patients off the bat, because we'd much rather not include patients with RV dysfunction and potentially miss a few that, would meet this if they did have adequate pictures, because, we're not really equipped to have an echocardiographer come to the STEMI bay and, assess the RV for all of these patients. So I think what we're going to do is rely on the CCU team. If we have inadequate pictures, that patient will be kind of ruled out immediately. And then we've also put some kind of other checkpoints for inferior STEMIs to make sure that we're not missing RV dysfunction. And that's if it is an inferior STEMI, so either an RCA or CERT culprit, once the diagnostic angiogram is done, we would only really include those patients if there's also significant left main or LAD disease. And for that reason, the reason that we've kind of included that is, if it's an isolated RCA infarct, and the patient is shocky, if there's no other disease, the left main or LAD, we don't really have anything to explain, LV pump failure. So, that's probably either missed RV dysfunction or missed MR or missed mechanical complications. So for those reasons, we're going to rely on the POCUS pictures in the CCU, but then have a number of kind of check marks to make sure that we're not kind of, inadequately assessing that and then including patients with RV dysfunction.
Yeah, I think it would be important to ensure you have the images recorded. So for quality control, you can go back and look and see, get other information. Obviously, you're going to get an echo at some point compared to that and so on.
Because it is very easy for our anteriors, because a lot of these will have LV grams. So
Yeah.
we'll know what their wall motions, we'll know that they have LV dysfunction. So everything for the anteriors can kind of be done in the lab. But you're right, the inferiors, the ones that we want to rule out, some form of quality assurance where our POCUS pictures are saved for reviewing post-procedure would be important. I agree.
How did you determine the costs for, like, you had number of CCU beds, number of ward beds, et cetera, et cetera?
Yeah, so basically what I did for that is I assumed that we put in 10 devices. Our retrospective analysis actually suggested it was 8.8 per year, but I basically took 10 devices and then multiplied that out by the difference in the DanGer treatment versus standard of care.
Got it.
So in DanGer, they had an additional 3 CCU days per Impella, and then 2 additional ward admission or ward days per Impella, and then the renal replacement therapy is also from that. Same with the bleeding.
Yeah. So I think it's exciting. I think the trial is compelling, but as you've already heard, there are potential gaps. And as much as randomized studies should drive our decisions, we know, we were driven by hypothermia decisions based on a randomized trial that ultimately proved to be not useful. So, and you mentioned there's going to be another trial in a couple of years. So I think we've always had at the Institute the ability to be nimble, to be able to advance things as we believe that they're in the best interest of our patients. All of these things we have to take into account. You pointed out the costs, and it becomes choices and priorities, right? So I think for this, you've outlined a beautiful protocol. I think having all the players involved and everybody supported, that's going to be key, including nursing, including allied health. You talked about the ward care and everything. What's the plan even for rehab and so on? So getting the whole pathway covered, the data collection and the quality of the data, ensuring using the ICCU database and ensuring that we're getting adequate and accurate data and careful review. I like the idea of planning some of the trials that you mentioned with other sites and so on. And we don't have this in the budget at the moment. And you said it's funded by the government and the hospitals. The government doesn't fund Impellas.
Yeah.
Not yet. We're working on that. So we'll need to have a clear pathway if we're going to try to be able to release funds to try to do this when it's not in the budget at the moment. So I'm not trying to, I'm just, this is kind of a reality check, and making sure all the ducks are in a row. It's, these patients are sick, clearly. This is high stakes, high costs. It's not saying we don't do it and can't do it. We can. It's just that we have to do it right, and it has to be a team-based approach and so on. I really like the more restrictive criteria. I do think you have to look at the age and bring that into the equation somehow. I think your notion of having the team-based rounds and so on, ensuring the right people are there, reviewing the patient on a regular basis is all going to be key.
Yeah, no, thanks so much for the comment. And I agree, what we've done so far is the easy part, right? And just like Dr. So said, putting the Impella is also the easy part. What comes next is, how do we fund it? How do we get all the key players involved? How do we take care of these patients afterwards? How do we develop all of these protocols? And then how do we start trials based on that? So there's still lots and lots of work to be done. But I think this is like you said, a great place to kind of start off.
Well done.
Yes, thank you.
Thanks so much. Thanks so much, Renee. That brings us to the end of rounds. Just a reminder to everyone, next week is the quarterly staff meeting. So for the staff, please sign in. Have a good week.